I am Ramaswamy Govindan, a medical oncologist specialized in treating patients with lung cancer. I'm a professor of medicine at the Washington University School of Medicine, Alvin J. Siteman Cancer Center. What we normally do in practice is that once we determine that somebody needs systemic therapy, we see them at regular intervals, ideally before the next round of chemotherapy. And basically in that visit, we ask fundamentally a few questions to see whether the therapy is having any adverse effects on the patients, particularly with regard to nausea, vomiting, fatigue, etc. And that is very important because that's the way you're going to assess whether to continue the same therapy or modify the doses of chemotherapy or systemic therapy. And then the second question I end up asking, or second set of questions, is the symptoms related to the disease. And there are patients who begin with a lot of cough or shortness of breath or coughing of blood, and they report after a round or two or cycle or two, they report to you that coughing is much less, or the shortness of breath has improved, or the pain has improved. So those things are useful indicators. But a more objective assessment comes with the CT imaging or the PET scan studies. And I typically do a CT scan of the chest and abdomen, the most common sites of disease involvement, after 2 cycles of therapy. That's about 6 weeks after starting a typical chemotherapy or chemoimmunotherapy or immunotherapy. That's a good time to take a look at what's happening with regard to the effects of the treatment. But before patients go for the scans, I do tell them right around the second visit that here is what we're going to look for on your CT scan. We are not looking to see whether the tumor has gone away. We're going to see whether the tumor has decreased or stayed the same. We look for only 2 things, I tell them. The tumor shouldn't have increased significantly, and we shouldn't be seeing new spots or new areas of cancer growth. In the absence of that, we would deem that treatment to be effective as long as the patients are doing well, otherwise with absence of significant side effects. I personally think this is very important because naturally the patients or the families are very concerned, and they're newly diagnosed with cancer, they're extremely anxious, and after 2 cycles of therapy, especially if they are doing well, their hopes naturally go up very high, and they expect the cancer to have melted away or have decreased substantially. And so it is important to prepare them earlier on to make sure that they know what to expect. And if they have an unreasonable expectation that this cancer is going to go away, even if the scans look very good and you as a physician get excited that the treatment is working well, you can almost see them quite deflated because the tumor has not gone away. The other important thing I would tell both the physicians and the patients, physicians in training and the patients, is that the CT scan or the PET scan shows the greatest decrease in size of the tumor after the first cycle of or the first 2 cycles of therapy. You don't see continued decrease in the tumor size after a few rounds of therapy. And it is also important for us to highlight that to our patients and their families, because if the cycle 2 shows that the tumor has decreased by 20–30%, the physician gets excited and the patients actually get very, very, very excited, and they become quite hopeful that the next scan would show further decrease in the tumor size, and once again get deflated when we don't see that kind of a response. So I think as physicians, we should be very careful in really setting the expectations so that our patients continue to enjoy or get the right perspective on what's happening with this tumor. The other question important to address is that, is PET scan necessary? Should we rely on a CAT scan or a PET scan? I don't think there is one right answer here, and I think doing PET scans every 6 weeks, I think is a bit excessive, and I usually use only CT scan. It gives better imaging of the lung anatomy, and we really get a good view of the abdomen. Occasionally, I do look at the PET scans periodically, particularly to look at the bones, and at this point, I do want to emphasize one more thing. One common thing we see is patients get chemotherapy, they do well, or immunotherapy, they do well. And then after the 3rd or the 4th cycles, you see the CT scan, the radiologist would report saying that the bone lesions look denser, look worse. And it is often the healing bone lesion rather than a progression, because the bone takes a while to heal, and then the healing process is not very organized and it looks very sclerotic sometimes. And so it is important to keep that in mind. So in the absence of any concerning symptoms, these lesions they represent healing bone lesions rather than progressive bone lesions. So that's something important to keep in mind. And then in terms of brain metastasis screening, I typically do an MRI of the brain every 6 months or so in patients with EGFR mutant and ALK positive lung cancer if they don't have any metastasis to begin with, because these patients are at high risk for getting brain metastasis. So I follow them along with a routine surveillance MRI of the brain. It is not really supported by any data, but that just anecdotally, I find that to be helpful. It can be a challenge with regard to getting insurance company approval for these processes, but something we do in practice. Of course, it's a different story. If somebody has brain metastasis, then we follow them more frequently, every 3 months or so.